functions like visuospatial functioning, executive functioning, and then focal cognitive functions in different parts of the brain. We will only choose clock drawing, which is an example of a test used for visuospatial functioning, in order to demonstrate its usefulness in assessing not just visuospatial functions, but also executive functions, which are frontal lobe functions, as well as the person's interaction and attention in general. So يوسف، اللي أبغاك تسويه أبغاك ترسم هنا في الورقة هذه كلها ساعة، ساعة حائط. استخدم الورقة كلها. استنى شوية، يعني ارسم، خليها ساعة دائرية وحط فيها الأرقام كلها، وبعدين حط لي الساعة على 11 ل 10 issue, or it's something that I found to be more sensitive in our patient population. So Yusuf has drawn a nice circle and is putting the numbers
11
ل 10. Now he's putting the hands of the clock. Okay. So this demonstrates a normal clock. So the components of the normal clock are a size of the circle seems to be appropriate. The numbers are well spaced. Many people with executive dysfunction, meaning difficulties in planning, will cram the numbers earlier on. People with neglect will only use one part of the clock and not use the other part. People with visuospatial functioning might not even people with visuospatial dysfunction might not even know how a clock looks like, or where the hands of the clock are supposed to point. This demonstrates that clock drawing is a simple, quick, and good screening test for multiple cognitive functions. And with this, I conclude what we wanted to demonstrate for the purpose of this video from the cognitive exam and the higher mental functioning, and we'll move on to cranial nerves. Assalamu alaikum. On to the second component of the neurological examination, which is examination of the 12 cranial nerves. The cranial nerves should be thought of as an indication of the integrity of the brainstem, because that's where the cranial nerve nuclei reside. Aside from the visual pathway and the olfactory pathway and the visual pathway, the brainstem harbors the pathways of cranial nerve functions as well. So moving starting with cranial nerve number 1, the olfactory nerve. We will not spend a lot of time on this because in any physical examination or neurological examination textbook you'll read that it's rarely done. It is useful to do to test cranial nerve number 1 in cases of head trauma, where the olfactory tracts might be injured because of their location in the olfactory groove at the base of the anterior compartment of the skull, where contusions might affect the frontal lobes as well, and the anterior temporal lobes. So the frontal poles and the temporal poles are important for olfaction. So in cases of head trauma, after a car accident, for example, or after a fall, sense of smell is something important to ask individuals about and to test. The other situation people might want to do that is if people present with behavioral disturbances of unclear etiology. So disinhibition, loss of social decorum, inability to reciprocate normal human interaction. And so this, again, thinking back to what I said in the beginning of the first compartment, this localizes to the frontal lobes, and the olfaction being part of frontal lobe function, it's sometimes helpful to test olfaction in people with behavioral disturbance. So, for example, a meningioma might press on the frontal lobes and the olfactory tracts running under them, and this might cause simultaneously behavioral disturbances and loss of smell, or disturbance in the sense of smell, olfactory agnosia, for example. Loss of smell is called anosmia. The third situation is in neurodegenerative disorders. So Parkinson's disease, for example, is highly associated with a loss of sense of smell that develops often years and years before the onset of the motor symptoms associated with Parkinson's disease. And to test olfaction, one presents a frequently, a common scent to the individual. One can put, for example, a little bit of mint, نعناع, ولا هيل, ولا أي شيء من هذه النوعية في test tube, and you present it to the individual, each nostril at a time, and you ask it to identify the scent. And there goes cranial nerve number 1, the olfactory nerve. Moving on to the more important cranial nerves, cranial nerve number 2, the optic nerve. So there are multiple components to testing the optic nerve. These are the visual acuity, which we will skip for the purposes of this test. One needs a Snellen card, and you basically show the Snellen card to the patient, and they will read the items from top to bottom. More often, people will send individuals to the ophthalmology clinic to test their visual acuity. And we will also not demonstrate color vision, which is closely allied. The second component, after visual acuity and color vision, is visual field. And we test visual field by confrontation. And we do it in this way. So, Yusuf, so it's important to have to be almost at level with the patient, and to have a sort of a line from your eyes to their eyes that's parallel to the ground. This is sometimes hard to accomplish if the patient is is on bed, for example. So you would have to lean over the bed like that and have that line parallel to the wall, for example, or something. But this is the most optimal situation to test visual field. You would have you would be level with the patient, and you would be sort of at arm's length or a little more from the patient. And we test visual field monocularly, not binocularly. So I would ask Yusuf to use this and cover one eye. And this way Yusuf is only using his one eye, his left eye, and I'm going to cover the eye that's opposite to me, so I'm going to cover my left eye. And then you compare your vision to the patient's vision, instructing them, which is an important point, not to move their head or their eyes. يوسف لا تحرك راسك ولا تحرك عينك، ثبت عينك كده على خشمي، وهتشوف أشياء تتحرك. لما تشوف شيء يتحرك قول لي.
شاي.
في شيء يتحرك؟
كيف؟
شوف يتحرك قول لي. My eyes still closed.
أيوه. أيوه.
أشياء عارفين.
الاثنين.
So, pitfalls. One needs to make sure that the stimulus is on-off in order to be able to really determine when the person is able to see the stimulus. So, meaning I don't want to do this, because this way the person might only see my moving stimulus here, and I might assume that he saw it even when it was there in the periphery. So that's pitfall number one. I would recommend using an on-off moving stimulus. In general, there are situations when other kinds of stimuli might be helpful, but I think in general, I would recommend using an on-off moving stimulus, just like that. And then you ask the patient to tell you when they see the stimulus and to point to where it is. Second pitfall is the hand should be in the middle. One should not do this, meaning closer to me, or like that, because this would not make our visual fields equal. So it is here in the middle that our visual fields, my visual field and Yusuf's visual field are equal. The third pitfall is that we should imagine the visual field as split into its two halves and four quadrants. So this is Yusuf's left temporal visual field. This is his left nasal visual field. This is his left upper temporal quadrant. This is his left lower temporal quadrant. This is his left upper nasal quadrant, and this is his left lower nasal quadrant. So what we want to do is we want to make sure whether or not Yusuf sees in each of these four quadrants. Therefore, the presentation of the stimuli at these four quadrants. So I would put my hand in this quadrant along with this quadrant and move one of them, and put my hand here and move it. So say, for example, Yusuf is not able to see in this quadrant. I would move my hand and ask him if he sees it, and Yusuf would not point to it, and I say, you really don't see it? And then I keep moving, so until I cross the midline. So he's either going to see it or not. If he sees it, it means that he's lost of this quadrant, and then I want to make sure whether or not he is able to see in the lower quadrant, so I move downwards. So people with a hemifield cut will not be able to see in one hemifield, whether it being temporal or nasal. And then I move on to the other eye. So Yusuf, I closed my right eye, which is directly directly opposite to him. And then once again, I am putting stimuli between me and him and in the four quadrants. وده ما نشوفش يتحرك بالشرايين. So this way I'm 100% sure that Yusuf sees in all four quadrants. If he didn't see in this quadrant, I would say, when do you see it? Tell me. He'd say no. I'd say, do you see it now? Do you see it now? Do you see it now? Someone with a temporal hemifield cut will tell me that they see it only when I cross the midline into their nasal hemifield. Someone with an upper temporal quadrant cut will tell me that they see it when I cross into the nasal upper quadrant or into the temporal lower quadrant. And people, so people will want to know the causes of homonymous hemianopia, which is a retrochiasmatic lesion in the optic tract or in the occipital cortex usually. People will want to know, and the causes of homonymous hemianopia are usually contralateral to the lesion is contralateral to the side of loss of vision. So a right homonymous hemianopia is caused by a left retrochiasmatic lesion. People want to know that a chiasmatic lesion causes bitemporal hemianopia, and people will want to know that a lesion in the optic radiation will cause a homonymous quadrant cut, meaning that if you only affect the temporal radiation in the temporal or parietal lobe, you will only get you will not get a hemifield cut, you will get a quadrant cut. If you affect the optic radiation going through the temporal lobes, you will get a homonymous field cut in the upper quadrant. If you do that in the parietal lobe, if you affect the optic radiation in the parietal lobe, you will get a homonymous quadrant cut in the lower quadrant. And these are important things to note both clinically and for exam purposes. So as you notice, we tested the periphery of the vision, and then one can map the center of the vision in some situations, like an optic neuritis, for example, but this is not really part of the purposes of this video. So the first component of testing the second cranial nerve, the optic nerve, is the visual acuity and color vision, which we did not demonstrate. We just demonstrated the second component, which is the visual field. The third component is the pupillary light reflex, which afferent is the optic nerve and the efferent is the third nerve. One wants to use a flashlight like this one. And what you want to do is you want to tell the patient to stay away. طول بعيد يوسف، لا تطل في النور، النور حيجي على عينك، لا تطل فيه، لا تطالع في اللمبة نفسها. Because if you ask the patient to look at you or look at the light, or if they do, even if you don't ask them, people will tend to converge, and if they do, their pupils will constrict. The expectation is that when you shine the light on the pupil will change size, will constrict, and you report the size before and after the light is shown in the eye. So Yusuf, طول بعيد. And what you do is, so you don't put your hand like this because people will look at it and accommodate. What you do is you come from the side, you do this, you go back. You do this, and you watch it again, and you go back. And you can watch the consensual or indirect reflex in the contralateral eye. Sometimes it's hard to see the contralateral, the indirect or consensual reflex. So what you do is you do you move in an arc-like movement and look directly at the other eye with the light on it. The first moments will be the indirect reflex that you had elicited by shining the light on this side. The following moments will be the direct reflex. So now I'm seeing the right direct, I'm moving, I'm seeing the indirect left, and I'm staying to see the direct left. And then I go back to see the indirect right. So that's the idea. So what I would do is this, and I'm done. Once again, I will do this, and done. I'm able to comment that Yusuf's size constricted from 4 millimeters to 2 millimeters, and they're equal and regular bilaterally. If a person's eyes constrict, or if a person's eye constricts with the indirect reflex, but then when you move on to it, you find that it does not continue to be constricted with the direct reflex, that's called a relative afferent pupillary defect. So for example, if Yusuf had a left relative afferent pupillary defect, I would move from his right eye to his left eye to find it constricted. I would keep the light on, but the eye would not keep constricted and it would actually dilate. This is called a relative afferent pupillary defect, and it tells me that there's a problem with the afferent part of the pupillary light reflex in the left eye. And this is often seen in cases of optic neuritis, which is often associated with multiple sclerosis. So this is how we do the pupillary light reflex. So one last demonstration. Patient looks away, you shine your light, you move in an arc-like movement, you go back to the same eye, and you're done. The last component of the testing of the second cranial nerve is the fundus exam. So you would use a ophthalmoscope, and you would look at the eye. You would examine, most importantly, the optic disc. You would look at whether or not there's papilledema, which is a sign of increased intracranial pressure. But we will not demonstrate it for the purposes of this exam, which is mainly focused on student level knowledge. Moving on to the third cranial nerve, which we will test along with the fourth and sixth cranial nerve because they all control extraocular movements. And at this point, it's important to mention an error that I commonly hear and see from people, that they confuse visual field with extraocular movement. So when I say examine the visual field, people will often start to examine extraocular movements or eye movements, and vice versa. And it's very important to distinguish in terms of terminology and in terms of functioning what the two are. The visual field is a perceptual function, and eye movements are really just, it's a muscular function, how the eyes are controlled by the brainstem and by the various extraocular muscles. So the way to do this is to have the patient look at an object and to tell them not to move their head. So يوسف لا تحرك راسك، طالع في الكلام، وحل ما يروح خلي عينك تروح معه، خلي عينك مركز معه. عينك تتحرك بس راسك ما يتحرك. تمام؟ So you can see, I noticed that in primary gaze, Yusuf's eyes are conjugate. Not one of them is deviated to the right or to the left, there's no strabismus. And then I would move slowly, not fast. If you move fast, people will not be using smooth pursuit and you will not have confidence in the intactness of their smooth pursuit system. So you move just like that, in an H-like pattern, and then you move in to look for accommodation. So, and then you ask the patient, شفت مزدوج في أي اتجاه؟ كان القلم واضح وواحد في جميع الاتجاهات. Say that Yusuf has, so as people know, the oculomotor nerve controls all eye movements except for lateral movement, which is supplied by the sixth nerve palsy via the lateral rectus muscle and the superior oblique muscle, which is supplied by the fourth nerve. By knowing that, we can deduce what the eyes will behave if there's a cranial nerve lesion. So Yusuf, say a patient had a right sixth nerve palsy, what they would do is when I bring the pen all the way to the right, this eye will move all the way immediately and this eye will not move or will move only partially, and you'll see more of the whites clearer apparent as opposed to what you see on the left eye. And they will start seeing double. So then what you would do is you would ask the patient what happens to the double vision when you cover one of the eyes. So you would cover one eye and then the other, and you ask them to keep looking at the pen. Keep looking at the pen. You know? And if they saw double, you would ask them what happened to the image. And in neurological diplopia, when there's a cranial nerve lesion, the diplopia will disappear. The person will only see one image, and usually the eye that you cover, and it leads to disappearance of the lateral and the outer or the outer image is the eye with the problem. So if Yusuf or a patient had a right sixth nerve palsy, they would see double when looking in this direction. I would cover this eye, which is the eye with the problem, and the outer eye, the outer image would disappear. If they had a problem with this medial rectus, the outer image would disappear when I close this. So the outer image will disappear when the eye with the weak muscle is covered. So let's talk about the third nerve palsy. In the third nerve palsy, the eye will be moved downwards and outwards. It will be pulled down by the fourth nerve and out by the sixth nerve, and the pupil will be dilated, and the eyelid will be ptotic. There will be drooping of the eyelid, or what's called eyelid ptosis. So the third nerve lesion and the sixth nerve lesion are important to recognize clinically. A bilaterally dilated pupil is a sign of herniation, transtentorial herniation. The brain will move downwards. The third nerves, which exit from the midbrain, will be pushed against against the tentorium, and this will lead to bilateral dilation of the pupil. So we've already started talking about the other components of the third nerve. The third nerve controls most of the eye muscles. It also controls the parasympathetic function to the pupil, and thirdly, it controls the muscle that elevates the eyelid, the levator palpebrae superioris. Therefore, a third nerve lesion leads to the eye affected being down and out, the pupil being dilated, and the eyelid being ptotic. The sixth nerve palsy leads to horizontal diplopia. That's just like we said, which is worst when the patient is looking towards the side of the lesion. With this, we will have concluded the third, fourth, and sixth cranial nerve examination, which is the examination of eye movements and extraocular muscles. moving on to the fifth nerve, which we have skipped because we wanted to examine the sixth nerve. So the fifth nerve has a sensory function and a motor function. Let's start with the motor function because it's easy and quick. يوسف سوي كده. See يوسف جز على أسنانه, and I can feel his cedar muscle on both sides, and I can see that they are similar in size, and there's no atrophy. I can feel his temporalis muscle on both sides as well. Relax. ريح نفسك. جز على أسنانك تاني. Yep. And I can feel them on both sides once again. ريح نفسك. سوي كده. So the muscles of mastication. ثبت نفسك كده خلينا نحركها. So I'm pushing against his jaw. ودي على الجنب الثاني. ونزل على تحت كده. So this is the motor part of the fifth nerve. Then there's which includes the muscles of mastication basically. Then there's the sensory examination, for which we would need a simple piece of tissue that's clean. So then you would basically test touch, focusing on the three divisions of the trigeminal nerve. So this is the ophthalmic division, this is the maxillary division, and this is the mandibular division of the trigeminal nerve. It's important to know where the different zones start and end. So imagine someone wearing their eyeglasses, and this part would be really the